Hello, I'm Alistair McCulloch. I'm really pleased to be able to present this work at the ADS. I'm sorry that I'm not able to be there in person. This presentation is accredited for continuing medical education. I have no financial disclosures. As we know, delirium is very common, affecting around 1 in 4 older people in hospital. Around 30% of delirium occurs after admission, but most of it's actually present at the front door. And so it's very important that we have processes in place to detect it at that stage, because it influences management from the time that it's detected. There are many tools that we use for delirium detection. Around 60 have been developed, but only a small number have ever made it into widespread clinical use. And even then, we don't know very much about how these tools perform in practice. In the last few years, there have been a few useful studies that have been published that have examined delirium detection at scale in clinical practice. And I'm defining these kinds of studies are those with N of more than 1,000, and which have also attempted to look at completion rates of the implemented tools, and also the important variable of positive score rates, so that if the tool is being done, is the rate of positive scores aligned with what you'd expect to see as the real delirium rate. And these 4 or 5 tools have been evaluated in this way. The 4AT shows moderate to high to completion with positive score rates that are broadly aligned with the expected score rates. The CAM shows very high completion in these studies of in the mid-90s to higher, but the positive score rates have usually been quite low, showing low sensitivity in day-to-day clinical practice. The nursing delirium screening scale has been evaluated in one study where completion rates were not reported, but the positive score rate was roughly aligned with what was expected at 13%. And a combination of tools has been reported by a group in Switzerland in these 2 studies by Schubert and Zipser, and they didn't report the completion, but I think the completion was likely very high, judging by what was written in the paper. And the positive score rates were pretty high in that study, of in the high 20s for one and 19% in the other. Now I'm going to describe the tool that's being used in the present study, the 4AT. This has 4 elements. The 4 A's are shown there on the slide. The first 3 are done at the bedside with assessment of alertness, the AMT4, which is a 4-point orientation scale, and an attention test, which is months of the year backwards. And the 4th A stands for acute change or fluctuating course, and this is mostly derived from information away from the patient, from case notes or informants, or yourself or other staff that know the patient, but sometimes the patient can tell you about change. And further information can be found at the website URL there. This slide shows the 4AT, which is the form that's used in many places around the world, and it's exactly the same form that was used in the present study. And you can see down the left are the 4 A's of the 4AT, and on the right are the scores that are ascribed according to the status of the patient. And I'd just like to point out that in items 2 and 3, there is an option to score the patient as untestable, and this is when the patient is unable to give a verbal response or to engage with the interviewer. This is quite common in patients with delirium, and this option avoids having to score the patient UTA, or unable to assess, and actually to give them a score. And this is the scoring system. So a score of 0 means no moderate or severe cognitive impairment, or makes it less likely. 1 to 3 is some cognitive impairment, but probably no delirium, and 4+ is likely delirium, and the scores go up to 12. The 4AT now has a lot of validation data. In this meta-analysis from 2020, 17 studies were evaluated with 3,702 observations, and the pooled sensitivity and specificity were both at 0.88. Since then, several more studies have been published. There are now 24 studies with more than 5,000 observations, and the 4AT is actually the tool with the most diagnostic test accuracy validation data of any tool in the literature. Now I'd like to move on to the objectives of the study. So we wanted to look at the relationships between 4ET done at the front door in routine practice and these three variables of 30-day mortality, length of stay, and home time, which is a variable that looks at days at home in the year following admission. And this incorporates mortality, of course, and provides an important balance to the competing risk of mortality. We used 4ET scores that had been entered into the electronic healthcare record in the first 24 hours of admission, and importantly, these scores were as completed by any frontline staff that happened to be working, so likely several hundred different staff of different types, so doctors of various grades, nurses and so on, completed the 4ET and entered it into the EHR. And in neither centre is specific 4ET training provided, although some delirium training is provided in each centre. We used two centres, Lothian and Salford. Now I'd like to move on to the results. First of all, looking at the completion rates, so these were 77% in Lothian and 49% in Salford. That means that the total N of 4ET completed was 52,965. And with respect to the 30-day mortality, people who had a 4ET score of 4 or more, that's a positive 4ET for delirium, compared with those with a 4ET score of 0, had 5.5-fold extra mortality in Lothian and 3.4-fold in Salford. We also did some secondary analyses of the 4ET scoring bands in relation to 30-day mortality, and found this quite interesting in that higher scores in the 4ET were associated with higher 30-day mortality. And this may reflect the fact that the 4ET higher scores would incorporate drowsiness quite often or untestability on items 2 and 3. And we know that drowsiness is a very strong marker for mortality within delirium, but also if it's measured independently of delirium. It's also notable that the scores of 1 to 3, which are cognitive impairment without delirium, also appear to be associated with higher 30-day mortality. We looked at length of stay in relation to 4ET scores, and 4ET not measured or 4ET 0 were associated with the lowest length of stay, and actually 4ET 1 to 3 and 4ET 4 plus were associated with a similar increased length of stay as shown there. There was quite a difference between the Lothian and Salford data, and we think this is because of a different case mix and also different discharge pathways in Salford versus Lothian. The third main analysis was to look at home time, and this is the number of days spent at home in the year following the 4ET measurement. And you can see in both centres a clear trend for higher 4ET scores being linked with a smaller number of patients at home in these different bands in the year following the 4ET. And this is an important measure because it shows that the 4ET predicts not only death but also potential disability and longer time required post-discharge in other facilities. We also were interested in looking at 4ET and longer term mortality, and we found that 4ET positive scores at the front door were associated with around 50% mortality at 1 year in Lothian and slightly less in Salford. And there was also evidence of this kind of graded effect with 4ET 1 to 3 having an intermediate level of mortality compared to 4ET 0 or 4ET not measured. This is the Kaplan-Meier plot for Lothian, with green being 4ET 0 and red being 4ET 4 or more. Most of the mortality seems to be occurring in the early part of the curve. A similar pattern is observed in the data for Salford. So in conclusion, This is a study which has a large sample size and which used data generated as part of routine care. I think it's significant that the 4ET was part of that retrospective methods were not used. It was a tool done quickly in real time, giving results to the practitioners at the time, as well as providing data for this study. Even though the 4ET is only a couple of minutes long, it was strongly linked with short and long-term outcomes. And these results, including the cognitive assessments data, show the value of doing delirium screening and cognitive impairment screening at the front door. The data generated by doing these tests affect practice in the short term, especially if somebody is diagnosed with delirium, as well as giving important information for clinicians in forward planning. Completion rates were mixed, and both studies started in 2016. Soon after, there was larger efforts to improve delirium screening. We know that from other centres that 4ET completion rates can be higher, for example in a hospital in New Zealand and across hip fracture care in the UK, where completion rates are above 90%. In terms of what the 4ET scores mean, I believe that it's important to emphasise that all delirium screening tools, even those I think inappropriately labelled diagnostic, require a clinician input before a diagnosis is made. That's because all tools have their imperfections and they're all kind of summaries of practice, so they can over or underdiagnose delirium, and they can also miss important parts of the story. So any data like this has to be taken in that context. Overall, though, I think the study does show both the feasibility at scale and also the clinical value of doing a very brief delirium assessment. And I'd just like to conclude with some data from across Scotland. So this is derived from Public Health Scotland data. Every hospital in Scotland reports here, and we've seen from around 2012 a large increase in the rates of delirium coding, especially in older populations. This is in the context of Scotland having a big push towards better delirium care with big policy focus, lots of education, introduction of the 4ET in 2012 in some hospitals, and gradually picking up steam over the decade, and also a push to use the word delirium. So there's many different factors, but I like to think that making a simple tool available at the front door and then seeing good completion rates has had an impact here. I'd just like to conclude by thanking the organisers again for allowing me to present this work. Thank you very much.